It's our regular live sessions. 2 weeks back we had, and we thought we'll discuss about varicose vein in this live session because it is often very, very difficult to understand different examination and so on. So I welcome Professor V Manoharan Sir, my good, rather not friend, my teacher rather, quite senior to me and rather moral supporter to me, very affectionate guide to me also. He's a professor from Manakula Vinagar Medical College, Puducherry. Sir, welcome you, sir, very much. Your support is
Yes, sir. Good evening, sir.
much appreciable always, sir. I welcome uh, Professor Muthukumaran Sir from Savita Medical College,
Thank you, sir.
head of the department and professor there, and he's also quite senior to me. Sir, thank you very much for allowing your student to present in this platform case presentation. Uh, I again welcome my friend, a very good surgeon and teacher, Professor Keshav Prasad from Sudhya Medical College. Keshav, welcome you. And I welcome Professor Robin George. He might join in, but we're not sure. He's on exam duty uh, from Tiruvalla. And Professor and HOD Sunil Joshi from Chikballapura Medical College. Sir will join in between. Uh, I again welcome Devika Ramanujam and Jeevika Jnanam, final year student from Savita Medical College. They are presenting the varicose vein case today. And under the guidance of Professor G. Muthukumaran there from Savita Medical College. I welcome all students who are joining this YouTube session online. I welcome everybody for the session without wasting much time. We'll straight away go through the discussion. Welcome Devika and Jivika. We present without any hesitation, whatever you want to know. Level good interactive session about varicose vein. Over to presenting Devika, no? History presenting Jivika
Yes, sir. I'll be starting.
or to Jivika.
Yes, sir. Thank you for this opportunity, sir, and a good evening to all the faculty present here. I'd like to thank sir for guiding me. Today, my friend Devika and I will be presenting a case of examination and discussion on varicose veins. Next slide, please. So, a 65-year-old male, farmer by occupation, residing in Kanchipuram, presented to the OPD with chief complaints of dilated tortuous veins on both lower limbs, right lower limb for 7 years and left lower limb for 4 years. Next slide, please. The patient history of presenting illness. Patient was apparently normal 7 years ago, after which he noticed dilated veins in the right limb 7 years ago, later developing on the left limb after 3 years. Initially, it was smaller in diameter, progressing to the current size in 4 years, extending from ankle to the thigh on right lower limb and associated with a history of swelling in lower limb at the end of the day, which was relieved upon elevating the limb. It is associated with itching for 2 years, dull pain on standing for long hours, with rest as the relieving factor. There was a history of darkening of skin over right lower limb 2 years ago, and a history of ulcers on right lower limb which healed spontaneously 1 year ago. No history of claudication, rest pain, or burning sensation. No history of abdominal pain or distension. Past history, the patient is a known hypertensive and was on medication for 10 years. No history of past hospitalization or immobilization following trauma, surgery, or illness.
Next, Deepak.
So for the treatment history, the patient is on a tablet Amlong 20 milligram HS for the past 10 years. Personal history, there's no history of smoking or alcohol consumption. Patient takes mixed diet, regular undisturbed sleep cycles with normal bowel and bladder movements. Family history, only one parent has a positive history of varicose veins. All the rest of the family history is negative and uneventful. To summarize the history, a 65-year-old male farmer presented with history of dilated tortuous veins on right lower limb for 7 years and left lower limb for 4 years. More in the right lower limb. Patient was apparently normal 7 years ago, after which he noticed dilated veins in right lower limb 7 years ago and left lower limb 3 years ago. It shows a progressive increase in the size of veins in 4 years, extending from calf to thigh on right lower limb, with itching and darkening of skin for 2 years, relieved on rest and elevation. History of hypertension for 10 years and on medications for the same. No significant familial history. A case of varicose vein with complications like edema, hyperpigmentation, and healed ulcer.
No, we'll go back to the history. Back. Deepak, go back. Go back. Back. Go back, Deepak, first slide. Next slide, next slide. Hold on, sir. Manoharan Sir, Keshav, Muthukumaran Sir, anything to comment on this? Sir, your voice.
Is it mandatory to mention the name of the patient, sir?
Here, because online, that's why they didn't mention the name, sir. There is no ulcer, Jivika.
No, sir. 1 year back, there was a history of spontaneous ulcer, but it healed, sir.
Okay.
But the picture shows left leg is bandaged, no?
There is a bandage. It is there. What is that inside the bandage? Have you seen? Have you opened the bandage and seen?
Yes, sir. There was no ulcer at the time of examination, so the history was based on what the patient said.
Okay.
No. Why is there a bandage there?
Why there is bandage?
He had an injury during the workplace, sir.
Oh, he had an injury there.
Yes, sir.
Yes. Sir.
That's why he was. He would have, okay. And the history presenting us would have mentioned that he had injury there.
Okay.
We were thinking that by looking at the photo, probably there is an ulcer there.
No, sir. No, sir.
Right. Okay. Sir,
Next.
Keshav, anything? Next slide will go.
Yes, sir.
Right, sir. Manoharan Sir.
Yes, sir. Yes, sir.
Anything to sorry? Like, anyway, sir. Anything to comment on this? Sir? Elevating the upon elevating the limb, it's relieved. All those things are okay. Itching is there. Dull pain, standing long hours, as relieving factors. All these things are okay. Chief complaint mainly pain, swelling, effects, ulcer, movement. You mentioned only pain and swelling, dilated veins. No other complaint you said in the chief complaint. Additionally.
Yes, sir.
So otherwise, if there are features of complication, then you have to mention that in the chief complaint. Then in the chronological order, you have to tell in the history of presenting illness.
Okay, sir.
Okay, sir. Manoharan Sir, Muthukumaran Sir, we'll go to the next slide. Anything?
Yes, sir. Yes, sir. Yes.
Next slide. So why darkening of the skin?
So because of claudication of RBCs, there's hemocyst.
No claudication.
Extravication of
Yes.
RBCs. There's hemosiderin depositions. So
Where
pigmentation.
You said claudication is a feature of what?
Arterial.
That's a pain and arterial.
Not in, okay.
Yes, sir.
Maybe
Sorry, sir.
not irrelevant here currently, at least.
Yes.
Sometimes venous and arteries may coexist. That time it is right, but here it is totally different.
Yes, sir. Yes.
You said ulcer has healed spontaneously, whether by on its own or with some treatment.
On its own, sir.
So you have not contacted anybody else, not gone for treatment, any hospital for that?
No, sir.
Any leading, because it has healed on its own.
Why you ask for abdominal pain and distension, ma?
Because if there is any tumor, it can be pressing and increasing the varicose veins.
Any secondary causes? Any secondary causes? We have primary and secondary varicose veins.
Yes,
Abdominal causes, whether you want by history, you want to rule out any
secondary cause.
secondary causes.
Okay,
Yes.
Why this is important in this case?
Sorry, sir.
Why this question is important in this case?
Advanced age, sir. So we rule out familial causes because it's familial ones will have a younger onset. At this age, a lot of carcinomas are common.
No, he has got bilateral. No?
To figure out if it's
Both lower limbs are involved.
if it's primary, then
Sir
there will be a
Sir is not asking, sir is telling you.
No, I am telling you, both the lower limbs are involved.
okay,
both
sir.
the lower limbs are involved.
Both. Which side is more common?
Left, sir.
Which side? Right or left?
Left.
But your case, it is right, you say, history-wise.
Yes, sir.
7 years, and after 3 years, the left leg started having the dilatation. Okay. So when there is bilateral varicose vein incidence, what do you think of?
What bilateral varicose veins? What you think of is the right question actually.
Congenital malformation, sir.
It's very rare. No? Not at this age. Congenital means you should have got it at a younger age group.
Okay.
So at this age, what do you think? Well, the level of obstruction, you can just imagine. Where should be the level of obstruction?
Common iliac.
Common iliac.
Common iliac.
Common iliac. Understand? So these are all clues for you to go back and listen. Yes, proceed.
I think here one more history of bleeding is very important. So you have not mentioned that. It's important complications which make the patient.
Yeah, that is important. You have to mention.
Sir rightly pointed out. The
Absolutely
first
right.
is bleeding. Any trivial injury, there will be profuse bleeding will be there.
And look at this varicose vein, so tortuous it is. So it is bleeding is not uncommon. Very commonly they come with the bleeding, and they won't notice also. It's a painless bleeding.
Okay.
Somebody else will notice the bleeding and tell you something is bleeding from your leg. And such a tortuous vein, look at the vein, it's more likely to bleed around ankle. You said pigmentation is there, and patient has had ulcer which has healed. The scar area may suddenly give way and bleed. So that negative history is important, like what Prasad told, no? Professor Keshav Prasad told. So you have to mention no history of bleeding anytime from the leg.
Okay.
This patient,
Usually, what the patient will complain, somebody with varicose vein, what is the classical way they describe?
Heaviness in feet and extremities.
The patient says during the course of the day, my limbs become heavy.
Yes, sir.
More appropriate for description. Okay.
Yes, sir. And darkening and eczema and itching on the darkened
What is it called?
pruritus.
What is all those things put together called? Darken, pigmentation, and other things. Any specific term?
Liposcleromatosis.
Lipodermatosis.
Dermatosclerosis. Lipodermatosis.
Dermatosclerosis.
Right.
Jivika, whether you have not mentioned, like sir has asked whether there is a night cramps, whether patient is having night cramps here in this patient. Heaviness, because those history is very relevant, important. Have you specifically asked it is there or not?
No, sir, I did not. I'll ensure to make sure next time.
You have to ask. That's a very important, relevant thing for the varicose vein. There is a they come.
The claudication, rest pain, and all not necessary, in this case, as sir rightly said before.
Another important secondary, I think in the next slide you have mentioned, but the questions you have asked. Can we see the next slide, please?
Next slide, we'll go to the next slide. Next slide. Next.
See, here indirectly you have made a passing comment on this, but more than that, you should probably ask for history of sudden pain and swelling in the leg. So that pain and swelling is very important. This last point, you have indirectly asked immobilization following trauma. What you are inferring?
Why you asked that question?
Yeah, keeping what in mind you have asked that history. That's what Keshav is pointing is very important.
Deep vein thrombosis.
Yes, very good. That's what sir is telling.
So for that, the question should be sudden swelling and pain in the lower limb. So that is more relevant. The question would be better Prem.
We have to mention there is no past history of appearance of sudden swelling, and there is significant anytime they remember it because very painful. Okay, they can't.
Because it's one of the most important cause of secondary varicose veins.
That's why it is
Okay.
important, and that is very relevant in managing a varicose vein.
Yeah. And treatment also is not different for primary and secondary there.
That is true. So that is important. You need to mention the negative history also important in managing such patients. So those things are important. Night cramp, heaviness. That is how they present usually. They come to you. And the ruling of the DVT just based on the initial history, at least history-wise, you think whether it patient has had all those things. So there are good point we have to remember. So anything to add, sir? Muthukumaran sir in the.
You mentioned regular undisturbed sleep cycles. What does that mean?
That night cramps are not
That's what Sir asked before. So
Indirectly, you mentioned it.
Indirectly, you mentioned. So you must always know whenever you mention some message you are trying to get across.
Yeah, night cramps. They can't have a proper sleep cycles.
Okay.
But straight away you ask the patient specific history, night cramp. That will be more proper way. Okay. So we'll go to the next slide. He's not a smoker, no?
No, sir.
Okay. The family history, you said one of the family members is having varicose veins.
Yes.
How severe it was, he had, whether he has undergone any surgery for that, he's wearing great bandage or stockings.
There was no surgery done, sir, but only compression stockings were used, and it subsided.
What is his occupation? Have you asked?
Yes, sir. The patient's father was also a farmer.
Farmer. Okay.
Yes.
That is also important.
So what is the syndrome associated with family in varicose veins?
What is the syndrome? Syndrome. If Robin sir is there, means he will definitely ask. His memory is very good.
Klinefelter syndrome.
Yeah, clean.
Okay.
Okay, and a few syndromes are associated, especially Klinefelter syndrome. That is very relevant in varicose vein. Okay.
Okay.
So need to think of that, at least keep it in back of your mind, because it will be asked in the exam when you discuss these things. What are the syndromes which are associated with the varicose vein? Okay. Sometimes AV malformations also will have a varicose vein in a congenital type, but they will have gigantism. Understood? So you have to keep that also in mind in a bilateral varicose veins in a tall patient. Okay.
Okay.
So we'll go to the next slide, sir.
Yes, sir.
Kumar, sir.
Yes, sir.
Anything to comment in this? Because he said a case of varicose with the complications are there. He said there are complications: edema, hyperpigmentation, and healed ulcer. Okay. Anything to comment on this summary, Keshav? I think. Muthukumaran, sir.
Nothing, sir.
This is a perfect. Always you have to write a summary after history. That is any long case important. It is very, very important. Don't forget.
Okay, sir. Okay.
Write a case sheet. Summary after history is very important, relevant before general examination. Okay.
Okay.
So we'll go to the examination, sir.
Yes, sir.
Yes, sir. Please.
Next slide, Deepak. So who is presenting? Devika?
I will be presenting examination, sir. Good evening. For the general examination, the patient was found to be poorly built and nourished. He was conscious, oriented to time, place, and person. He was cooperative. The patient's consent was sought before examination, and there was pallor present. There was no history of icterus cyanosis clubbing or generalized lymphadenopathy. There was unilateral fetal edema on the right limb up to the ankle. The patient's vitals were as follows. The BP was 130/90 mmHg. Pulse rate was 84 beats per minute. Respiratory rate was 20 breaths per minute. The saturation was 98%. Patient was efficient. And we have also mentioned the performance score.
Next slide.
Next, please. Yes. So the patient's privacy was ensured. He was taken to a safe to a private region where he could be examined. His consent was sought, and the patient was given the instructions. So initially, upon inspection, we found dilated, elongated, tortuous veins along the medial aspect of the leg, and they extended from calf to mid thigh. There was edema in the foot and the ankle, more so on the right limb. There were visible skin changes. There was increased pigmentation in the right leg, involving the foot, ankle, and lower leg. There was an irregular hypopigmented scar over the medial malleolus and shin, measuring 1 cross 2 centimeter and 2 cross 2 centimeter respectively. And these were suggestive of healed ulcers. And there was no history of loss of hair, brittleness of skin, glistening of skin, stretched skin, or redness of skin. Next slide, please. Upon palpation, both the limbs were palpated. The right limb is first described here, but both the limbs were not warm, not tender. There were dilated veins from the calf to mid-thigh, and they were palpable. I'm sorry for the error, it's not mentioned there. There was thickening of skin present, and there was spitting pedal edema on the right lower limb. The girth of both limbs were measured, the right limb measuring 37 centimeter and the left limb measuring 36.5 centimeter. The girth of the calf, that is. Subsequently, the tests for varicose veins were performed. The patient was given the instructions. So, for Trendelenburg test 1, the patient was asked to lie down. The limb was elevated and the veins were emptied by gentle tapping. Then the saphenous opening, which is 4 centimeter below lateral to pubic tubercle, or 2.5 as per Bailey, or 3.75 as per your textbook, sir. It was occluded with the thumb and the patient was made to stand, and the pressure on the saphenous opening was released. It was found that there was rapid filling from above downwards, and this gives us the impression that there was saphenofemoral incompetence. Next slide, please. In the second test, the patient was again asked to lie down. The right lower limb was elevated. The veins were emptied by gentle tapping. The saphenous opening was occluded with the thumb, and the patient was made to stand, and the pressure was not released. We found that there was filling from below downwards, and this gives us the impression that there is presence of perforator incompetence. Then the multiple tourniquet test was performed. The patient was asked to lie down. The limb was again elevated. The veins were emptied. There were multiple tourniquets tied over the site of perforators. We have done it using 4 tourniquets. One right below the saphenofemoral junction. Second one was at mid-thigh. Third one just below the knee. And the fourth one was the palm spread above the medial malleolus. And they were released gradually from below downwards, and we looked for filling of the vein. The finding was that there were dilated tortuous veins, which were segmental, along the medial aspect. We found them above the knee, below the knee, and above the medial malleolus. And this gives us the impression that there is incompetence of perforators of the adductor canal, the below knee perforators, and the leg perforators. Next slide, please. This next test was modified Perthes test. The patient was asked to lie down. The lower limb was elevated. Veins were not emptied. The tourniquet was tied over the saphenofemoral junction, and the patient was asked to walk. And there was dilated veins. There was no pain, and this helps us rule out DVT. Next slide, please. For Morrissey's cough impulse test, the patient was asked to lie down. There was a thumb at the saphenofemoral junction, and there was an expansile cough impulse felt. For the Schwartz test, to check the patency and the communication of the long column of vein, when the dilated visible vein is tapped, the impulse was felt at the thumb, at the upper visible part of the vein. Then in Fegan's test, the areas of blowout are clearly visible here, and when they were palpated, we found buttonhole deformities. Next slide, please. In some conclusion, initially, to rule out saphenofemoral incompetence, there was Trendelenburg test 1 done, and it was found to be positive. Then we looked for perforator incompetence using Trendelenburg test 2, which was positive. There was filling of veins from below, and then the tourniquet test was performed to ascertain the site of the perforators which were incompetent. And this helped us find out that adductor canal perforators, below knee perforators, and lower leg perforators were incompetent. TRATS test was done. Here we could see visible blowouts, and they were palpated, and we found soft compressible swellings. Segan's test was done to identify areas of blowout, and we palpated buttonhole deformities. To rule out deep vein thrombosis, the following tests were done. Modified Perthes test was negative. That is, there was no cramping pain in the cuff. And the subsequent tests for deep vein thrombosis were negative as well. Next slide, please. The gait of the patient was observed to be normal. The ankle joint movements were normal. There was no restriction, pain, or difficulty. All peripheral pulses were felt. In the inguinal region, the lymph nodes were examined, and there were no palpable lymph nodes. CR examination was normal. On the opposite side, there were reticular veins extending from 10 centimeter above the medial malleolus to below the knee. It was 5.2 centimeter in length. No skin changes were associated with it. The other system examination, cardiovascular, normal S1, S2 was heard, no murmurs. Respiratory system, there were normal vesicular breath sounds. There were no added sounds. Abdomen, no palpable mass or dilated veins over the abdomen. The CNS examination, there was no focal neurological deficit and no sensory motor deficit. In conclusion, we had a patient who was a 65-year-old male presenting with complaints of dilated, elongated tortuous veins, which were more predominant on the right lower limb, and they had a diameter of about 6 millimeters extending from calf to mid-thigh. It was associated with pitting pedal edema of the right limb, hyperpigmentation, and scars which were suggestive of healed ulcers. Upon examination, Trendelenburg test 1 and 2 were positive, which indicates saphenofemoral incompetence and perforator incompetence. Multiple tourniquet test was done. It helped us pinpoint the site of perforators which were incompetent. So the adductor canal perforators, below knee perforators, and lower leg perforators were found to be incompetent. Modified Perthes test showed engorged veins, and it ruled out clinical evidence of DVT. And in addition, we identified multiple areas of blowout. Thanks.
Next slide.
So based on this, we arrived at a provisional diagnosis that it was a case of primary varicose veins on right lower limb involving long saphenous system with saphenofemoral junction incompetence, adductor canal perforators, below knee perforators, and lower leg perforators incompetence. It was associated with complications without signs of DVT. Hence, we arrived at the CAP score of C5, EP, AP, PR.
Okay, no. We'll go back to the examination. Go back. Deepak, go back. Go back. Okay, here. Next slide. Next. Okay, hold on. Sir, Manoharan Sir, Keshav, Muthukumaran Sir, this anything to comment in this? Why is not history of loss of, by mistake you are written, I think, no history of loss of hair, brittle cephaline, nail.
All arterial insufficiency.
You are mixing two things, no?
Yes,
This
so
is
that
history of your observation.
Varicose vein, you talk about edema, calf muscle tenderness, and things like that. Okay. Loss of hair, brittleness is all vascular arterial insufficiency, isn't it?
It's insertion probably by mistake.
Redness of skin.
Redness
of skin.
to rule out thrombophlebitis.
Very good. Okay.
Okay.
Next slide.
That becomes relevant. That is relevant.
It is relevant.
That is relevant.
Next slide.
Next slide.
Okay.
Thickening of the skin present, palpation. No inspection only that much, is it? No backside, no short face, no penis visible. Blowouts, thigh, leg. You said pigmentation, scar is. You said the scar is there. Where is the scar? You have not mentioned scar. Where is the scar?
On the inspection, sir, previous slide. Could I please?
You said there is scar, healed ulcer,
Two healed scars, you said, man.
history you have told.
Yes,
So
sir.
on inspection, you have to mention where exactly it is, where around the ankle, in the lower leg, or
Location.
medially or laterally. Those details have to be mentioned, I think. No, sir?
Yes, sir.
Manoharan Sir, Keshav? I think it should be mentioned inspection in detail. Where are these, this one, and which veins also you have to mention on inspection. Long saphenous vein or short saphenous vein, from behind, medial malleolus, lateral malleolus. Detailed inspection is required. Okay, much more detailed inspection is required. You have mentioned somewhere examination of standing.
Yes, sir.
Somewhere you because it is important. In hernia and varicose vein, examination of standing is most important. First, when you start inspection, first thing you have to write is inspection is standing. Okay.
Standing.
Even in hernia, it's the same. Inspection standing. That first word is very important. You have to mention that. If you are not mentioned, you have to mention. And scar and other things also. Once you mention scar, where is the scar, how big it is, how it has healed, whether it's medially, laterally, everything is relevant. Okay. Only medially veins are there, laterally no veins, posteriorly no veins.
That's what single.
Yes, sir. We have added an image, sir. I think it's there in the last slide, sir, of examination.
There are no veins on the, because you have to inspect around the leg, both legs from front, side, and back from the back. You have to around the leg, both front, behind, round the leg. You have to inspect always. It's very important. You have to inspect on standing. Most important. These two factors you have to always inspect. Okay. Palpation. You have palpated the veins, no?
Yes, sir.
Okay. Anything to comment on this, sir? Manoharan Sir, Keshav?
No, sir. I think it's
Muthukumaran Sir.
Again, girth of the limb is it relevant here?
Yes, sir.
What is the relevance?
I'm sorry, sir.
What is the importance of
You
girth?
mentioned
In gigantism in AV malformations and edema or edematous changes, and as per Wells criteria, greater than 3 centimeters is considered, a difference of more than 3 centimeters is considered significant in DVT.
So any point if you mention, you must be in a position to tell the reason for it.
Very true. Detailed thickening of the skin. That is all those eventually effects of
which vein you are talking about?
Sir, with, the ones which are visible along the medial.
Is it the great saphenous or the short saphenous?
The great saphenous, sir.
Where you have mentioned?
You have to mention, no, because you are the clinician.
territory.
No.
Medial side of the leg, medial side or lateral side, you have not mentioned. Whether it is a single vein or whether it has got multiple branches connecting, all those things.
Whereas the communicating veins are visible.
So the course, the entire course of the vein from starting from the ankle to the leg, thigh up to the saphenofemoral junction, you must describe. It's not only focal in particular area, isn't it? So those description is all missing here.
So
some areas it may be ballooned out. Some areas it may be single. Of course, we agree that it is a dilated artery. Is it a single vein throughout the course, or it is having multiple veins as far as in the lateral aspect posterior? Is it there or not?
Yes, sir.
Absolutely right, sir. Here you have to mention which vein specifically. From where to how far it's extending also you have to mention.
Is the short saphenous involved?
No, sir.
You have not mentioned.
You have to mention short saphenous. It's very important, no? The short saphenous is involved or not, you have to mention. Let's say from behind how it looks in front, and palpation from laterally, medially, along the course, and
The inspection itself, we have to say from the anterior aspect, lateral aspect, posterior aspect. So we may have veins on the other sides also, and whether they will be connected. All those things you must say. Okay. Go to the next slide. Next slide, please.
Yeah, that's important point. You have to mention which vein, and short saphenous vein you have to mention whether it is visible or not, and whether it is on palpation, it will be able to feel it or not. And if you think there are short saphenous vein, then you have to do a tourniquet test for that also. It's simple to do, but you have to do it. So examination all around the leg is very important. It's what Manoharan Sir is highlighting. That point is very, very important.
Where does this vein start?
Sir, it originates from the arch, the
Which
dorsal
arch?
venous
No,
arch.
in this patient.
From calf to mid thigh, sir.
Calf where? Medial side, lateral side?
Medial, sir.
No, your picture does not show the foot and the ankle at all.
I think next picture it is there, I think.
So you must say always from the dorsal venous arch, from the medial side, it doesn't know. So we would like to see whether there is any dilatation there itself, around the ankle especially. Why that is important?
Corona of lipectasia
No,
and the
you
perforators,
said-
dot perforators.
No, you said some 2 ulcers, healed ulcers.
Yes, sir. Gators area is a common
That's
site.
what we want, because varicose ulcer classical site is above the medial malleolus. That's why you should know whether the course of the vein corresponds to the location of the ulcer. Okay, right. Okay, ma'am. Next slide.
So that's important, like sir told, entire length of the vein examination and mentioning which vein. And which vein is not there also you have to mention. The negative finding also important. Short reference vein is not visible, not palpable. That finding also important, which is not mentioned here. Understood? You name, because you know the anatomy, you have to name it and inform. That's the
Yes.
important thing what sir is highlighting. Is it clear?
Yes,
Okay.
sir.
So next slide.
Yes.
Okay. Sir, anything to comment on that? Pressure was English
So,
defined.
what is this? That specific word in all the slides you have put tapping. Why you should tap the vein?
We will milk the vein because
If you elevate the limb by gravity, it becomes empty. The maximum you can run your hand over the course of the vein. What do you call it? Milking.
See, tapping is like this. Milking is running your finger. Right?
The veins usually we don't tap now,
Not
unless
tapping.
you are planning to put a Venflon or IV cannula. That time you may tap to locate the vein. Okay.
It is a milking, it is not a tapping.
So I should appreciate you because all the tests you have written very detailed in this thing thoroughly, and one or two few this kind of small things are there. So can you tell me
Sir,
how you do the test? How you do the test? You just tell me.
Sir, they have to use tourniquet, I think. Ideally, tourniquet is better, rubber
Tourniquet.
rather than thumb. Thumb is, it is there in the clinical book, but better to use
Tourniquet
tourniquet.
is better because if you miss the 1 centimeter away from the subnus opening, the test will give negative or positive result, no? So where do you locate this subnus opening? Where is it?
So 4 centimeter below lateral to pubic tubercle, or if they use it to
So
We mark
actually,
it.
there's
Subnus opening marking is important. That's what sir is asking. Which is not,
Elevate the limb
not
and tie the
mentioned.
tourniquet at that level. That means you are sure that you close the opening. Yes.
So marking is important, which is missing in the slide. Okay,
Okay,
it's
sir.
important. That's what sir is highlighting. So
Okay.
you are told that where to mark. Yeah, when you present, you are told 4 centimeter below and lateral. That point you have to mark that point, and ideally use the tourniquet in the exam, not thumb.
Not the
We
thumb.
expect you to use tourniquet. Okay,
So he
rubber
says
tourniquet.
pressure on subnus opening was released when?
After the patient was stood up, it was released.
Immediately after standing, immediately you release that and rapid filling from above. So that shows there is subnofemoral incompetence. Agreed. Good. Next slide.
Next slide. So tourniquet you have to use, not thumb. Thumb is, we are not questioning it. It is right, but ideally tourniquet, remember. Okay.
Right lumosal. Veins were emptied by gravity and milking. Okay. Right. Subnus opening again. Subnus opening was occluded with the tourniquet.
Tourniquet.
The patient was made to stand without. That is because tourniquet is there. Unless you release it, the pressure will be maintained. You understand now the meaning?
Yes,
So
sir.
when you will remove?
In Trendelenburg 1, it's
Not 1 is over. This is 2.
So when you will remove, how long you will wait?
30 to 60 seconds. Sir.
How long?
30 to 60
to
seconds.
60 seconds, she says. Maybe a minute or two. Okay.
Minute or two actually, not second.
Not seconds.
Second for 1 minute is. It is for 2, you have to wait for 2 minutes. That's what I think.
Okay,
Sir is
sir.
right actually. You have to wait because it takes time to fill from below upward. You yourself have written gradual filling.
from below
There
upwards.
is one, it is a rapid filling. Here it is a gradual filling. So gradual filling takes time.
Okay, sir.
Understood?
Yes,
So again,
Gradual filling is normal, no, Devika?
Sorry, sir. Yes, gradual filling is normal. Rapid filling indicates
yeah, this is what
If there is rapid filling, then you call it as
there is incompetence.
which
Yeah.
which incompetence?
Perforator
Where?
incompetence.
Which perforator?
From below.
how will you know that? How will you know with the test to which perforator incompetent? It is not possible to point out. You need to do the further test.
Somewhere near the tourniquet, isn't it? That's why that is getting filled up. Right. Okay, next slide.
Next slide. So tourniquet spelling is wrong. TOUR. All level tourniquet spelling you are written wrong. Okay. Correct your spelling. TOURNI. Okay.
What is the purpose of doing this test, Devika?
This helps us identify the site of perforator incompetence.
Right, level of perforators.
Level of perforator.
Level of perforators. So you tie 3 tourniquet and then you slide the tourniquets at various levels. So identify which side there is perforator incompetence. That is a proper method of doing it.
Okay, sir.
So empty the vein, apply a tourniquet SFJ, then above knee, below knee, and around ankle. At least minimum 3 tourniquet you have to use. 3 or more tourniquet. Then ask the patient to stand, then release the tourniquet from below upward.
Easier way is at the level of subfemoral junction, above knee and mid thigh.
Mid thigh, 3 minimum. That's why 3 minimum.
3 this thing, then you see which one is that, then you slide these tourniquets below knee and then identify.
That's what. Often it is, that's why it is often called a 3 tourniquet test. So it is 3 or more tourniquet. That's why it is better to be called as multiple tourniquet.
Can you name the perforators?
The Hunterian perforator, sir, adductor, and then Hunterian, Dodd, Boyd, and Cockett, sir.
Tell the level. Tell the site.
Sites, nowadays we don't call that anatomical level only we talk now.
Hunterian is above where it is.
Hunterian is above the adductor. That's the adductor canal perforator. Then there's a mid-thigh perforator, below knee perforator, and lower leg perforator.
Okay. So many names, you can just, maybe useful for your MCQ, for NEET exam, those names. But it is difficult to remember. But this, like sir rightly told, anatomical level you have to mention. If they ask, you can tell in the exam, or tell I forgot the name. It's difficult to recapitulate. But MCQ may require, we are not sure about that.
Yes.
So again, use the tourniquet, that's important. Release from below upward. First SFJ, empty the vein, milk the vein, not tap the vein. Okay, that's the point sir has clearly pointed out. Then release the tourniquet from below upward. Before that point, you can see the blowout wherever it is there before releasing the tourniquet. You may have to repeat the test 2 to 3 times to come into conclusion where exactly is the perforators are incompetent. Maybe 1, 2, or 3. So one sitting may not be able to come into the conclusion. You may have to do it 2 or 3 times to have a very clear idea and mark the perforator. It's the point which is you have to remember. Okay, it's called the Oscar Manoharan test. Okay, if you're able to remember that one, that's okay. So that is multiple tourniquet test. So again, use tourniquet as such, not thumb anywhere. Okay. So anything, sir? So all these at least anatomy level.
Devika, what do we use for tourniquet?
Sir, I'm sorry.
Tourniquet is available.
Available.
In your
exam.
Rubber tube should be carried.
Who should carry?
The student should carry it to the examination.
Otherwise, if the rubber tube is not.
Glove.
Huh?
The
Glove.
glove.
Whose leg? You cannot tie glove to my leg, no?
It is difficult unless.
What is easily available in the wards? White color rolled.
Bandage.
The gauze.
Bandage.
Bandage.
Bandage you can use. We used to do that. Bandage.
Easily available always.
Rubber tourniquet is not available. At least you can say bandage is available. You can use it.
Safe for this.
4-inch bandage you can use. Okay.
Next slide.
Next slide. So there was a confusion here. Patient was
First line. I want Keshav Sir to comment upon.
Keshav was
modified pathis, we don't do anything at all.
See, if the patient is lying down, then the vein is already empty.
Vein will become empty, no?
This test is done standing only.
Standing only, you don't see.
Tourniquet test was
Only test where we don't elevate, we empty and make the patient lie down. It's modified.
means you will never empty the vein in a modified
Right
pertest.
at all.
DVK and DVK. Remember,
Patient will stand as it is.
you will never empty the vein in a modified pertest.
So first two lines are
Not required.
not required at all. Has
Not
to lie
required.
down and
Contradictory.
elevate. Both are totally contradictory. So you should not do that.
Lying down elevation will empty the vein. But the third point you mentioned, not emptied.
Not emptied. Okay, then
Then why you want to elevate
you lie down and elevate, the vein will become empty now.
You will never empty the vein in a modified pertest. In standing, apply tourniquet, SRB junction.
Yes,
Then after patient have a brisk walk, then they will feel the bursting pain. That's the most important. And a prominent vein, more prominent veins become more prominent. So
Why the vein becomes more prominent?
Initially, when he stands up and walks, the contraction of the gastrocnemius directs the superficial venous flow into the deep venous system. So the vein should ideally collapse, but in this case, due to deep venous being occluded or obliterated, the superficial venous system starts to engorge and become visible.
Exercise induced venous flow. The vein will bulge. Isn't it? Yeah. More and more walking, more blood will come into the vein. Pressure in the superficial vein will increase. So your tourniquet is preventing it from flowing towards the subnumfemoral junction. Is it not? The vein will collapse means what? It is able to flow through the perforators into the deep vein. That means deep vein it is patterned. Suppose, as Sir said, the patient, the vein is becoming more distended, becomes very painful. What is that pain? Extract type of pain. Sir said no. Deep
what
vein
type of pain is most important?
Bursting.
Bursting pain.
Bursting pain means that its deep vein is thrombosed. Okay, that is the principle of this test. So the first two lines, now no lying down, no elevation.
No, so first two lines are wrong. Okay, in standing, we will never empty the vein. Just apply tourniquet. Okay, then have a brisk walk. This is the point. Bursting pain.
So finding what you should write: dilated tortuous vein with no pain or something else.
With no bursting pain.
No, dilated tortuous vein which will collapse. It will shrink in size. That means blood is able to go through the which one?
Into the deep venous system.
Through what? Perforators.
Through the perforators.
Through the perforators, it is able to go into the deep vein. Deep vein is patterned. That's why patient does not have pain. That is the meaning. Clear. Dilated tortuous vein will collapse, or it becomes more prominent and distended. Means deep vein is thrombosed. You understand?
Yes, sir.
So this is a very important test, but the mistakes already Sir has pointed out. Remember, GVK and DVK. Okay, so that's the point. Never empty the vein when you do this test. It's most important.
Okay.
Remember. Okay, so we'll go to the next slide, Sir. Keshav.
Yes, sir.
Okay, Morrissey's cup impulse. You do it in the lying down position or standing?
Lying down, sir.
Lying down position.
Okay.
So it is done in lying down, sir. It is done in lying down. Short test, what is the importance of short test?
It finds out if it's a continuous communicating column of blood in the vein.
Right. What does that mean? What does that mean to you? Continuous column of blood. So what does that mean to you?
That there is no
no venous valves. All valves have become incompetent. Understand? That's why it's fully filled. What is the shape of the valve?
The shape of the valve, sir?
Valve, shape of the valves.
Not sure, sir.
Cusp shaped. Cusp.
Okay.
Like this, something like this. Okay? Like this, cusp shape.
Cup shape, yeah, it's cup shape. And it is incompetent. So whatever the valves are incompetent from the site of the tapping, from the site of feeling. Here tapping comes. Understood? Not everywhere. Here you have to tap. Okay, when you this one, okay. So that is your test. Fagan test. What's the relevance and how to do that?
Sir, the areas of blowouts, we feel it, sir, and we find a buttonhole deformity where the veins are piercing the deep fascia and entering. At those sites, it can be palpated.
How to do that?
Sir, we can either tie the tourniquet, ask them to cough, and then the regions of blowout appear,
Cough,
But
you
in this,
cough.
No.
Why you want to die a tourniquet for vacant stress?
no, tourniquet, just cough.
No, you have done it. You tell how you have done it.
So in this case, the areas of blowout were visible.
Jivika, you can help her. If you got same idea, means there is no point. How exactly you'll do Fagan test? Very important test.
I'm not
sure. Okay. I will tell.
Standing or lying down?
Standing, you have to see the blowout. It's visible. Then mark the blowout. Then elevate the limb. Then run your finger. Elevate the limb and run your finger over the beam. Then you can feel the whatever she said, crescent-like depression, where it's a part of deep fascia where it is perforating. So both in standing and then elevating limb in lying down position, you have to do the test. It's a very important test. Fagan originally told like that: standing, check, mark it out, then elevate the limb, then run your finger along the vein to feel the crescent-like depression. Understood? That is how exactly you will do. You'll never put. There is no tourniquet comes here for Fagans. Don't tell tourniquet emptying the vein, all those things. Okay, that is not relevant. Very clear. In standing, run your finger and see the blowout. In elevate, run your finger and see the crescent-like depression in both positions. First standing, then lying down, elevating the limb. Okay, is it clear? Any confusion? No confusion. No tourniquet. No emptying, no milking, all those things. Okay.
Yes, sir.
Okay.
So that's very important test, at least in olden days before the era of Doppler. So anything to comment? Keshav, sir, we'll go to the next slide.
Next slide.
Yes, sir.
Okay. Next slide. Okay, this anything to comment on that? Spelling was correct here, tourniquet, but Homan sign spelling was wrong. HOMA single N it is.
But clinically, you are not supposed to do that Homans and Moses.
Yeah, Homan sign Moses.
Half muscle tenderness, it is understood.
Okay.
So what is the problem in doing this?
Sir, it dislodges the thrombus and it can cause
You know it, then why you want to do? Half muscle tenderness is just a convention and this thing. Okay, proceed. Right.
Okay. This slide is good. You have made this slide. It's
Very nice. All the
very nice slide actually.
nice slides you have made. Yes, sir. Next.
But sir, like sir rightly told, it was just mentioning Homans and Moss signs. You
Yes.
don't demonstrate. You may dislodge the clot. That point you have to remember. Okay, this slide is good anyway. Good. Next slide. So everything she has mentioned. Sir, anything to comment, Keshav?
What type of gait you will get if there's a complication in patients with varicose veins?
Sir, there's talipus equinus
Talipus equinus.
Yes.
deformity. So the patient walks on their toes.
Like a horse walking. Talipus.
Yes.
We used to see that when we were 30 years back. Now it is not that common to see that to that level. Ankle joint movement is important. What are the ankle joint movement?
Intorsion, extorsion, and flexion.
Louder.
Distortion.
Sorry,
Inversion.
inversion.
What
Sorry,
ankle
inversion.
joint means?
Dorsiflexion and
What type of joint is ankle? How many movements are there on ankle?
Dorsiflexion, plantar flexion,
Okay.
hinge joint.
Yeah, so only two movements, no, in hinge.
Only two movements, no? Inversion, eversion, which joint? Same ankle joint or something else?
No, sir.
Below that.
Below.
So ankle joint only dorsiflexion and plantar flexion. Inversion, eversion in the subtalar joint. Both are different joints. You have to remember.
NMC removed orthopedics from the UGs. So this is what happens.
So dorsiflexion, plantar flexion, ankle joint, inversion, eversion, subtalar joint. Don't get confused. If somebody asks, so what are the movements of ankle joint? Only two, like hinge joint. Like Keshav is very clearly pointed out why it is so. Dorsiflexion, plantar flexion. Whereas inversion, eversion in the subtalar joint. It should be very, very clear which movement. Don't get, because most of the students will tell inversion, eversion also from the ankle joint. It is not so. It is from the subtalar joint. This confusion should not be there. Is it clear? Any confusion?
No, sir.
Clear? Okay.
Yes.
So exactly, should remember that the point is very nicely raised by Keshav actually. So palpable lymph nodes, when there is inflammation, infection is there. Other side, of course, it is there. We are not going to do. What is reticular vein means?
So when the diameter is less than 3 centimeter, when it's between 1 to 3 millimeters, it's considered reticular vein.
Less than 1 millimeter, what is called as?
Telangiectasia.
Thermal veins or telangiectasia.
Thermal flare.
Clear. Okay, that's right. So anything to say? We'll go to next slide.
Yes, sir.
Next slide. So other symptoms, abdomen already sir has discussed, no palpable mass, no dilated veins. What is the significant dilated veins in the abdomen?
Abdominal.
IVC obstruction.
IVC obstruction. IVC obstruction will have it. That time we have to always check the movement of the standing. You have to look for, and you have to check the direction of the flow.
Direction of flow.
Okay. Usually above the umbilicus into the axillary vein or superior vena cava, below the umbilicus into the IVC. So direction will be reversed if there is obstruction. That point you have to remember. Always examine in standing and check the direction of flow in both places, above the umbilicus level and below the umbilicus level. Okay. So anything to come in? Nothing, no sir. We'll go to next slide. Sir, next slide. So this is the final summary, whatever she has told already. We have discussed, sir. But she has never mentioned which vein here also. SFG, she has mentioned.
But it has been kept a secret.
Secret. Main point is missing.
Which vein
Till the end, we don't know which vein it is, whether it is great saphenous or short saphenous,
or saphenous vein.
and both limbs. Okay.
So next slide. So right here saphenofemoral they have mentioned, but great saphenous vein, varicose vein you have to mention which vein.
She's mentioned, sir, long saphenous system.
Okay, that vein name is important. Okay, so that you have to mention. Don't worry, that is. But SFD they have mentioned definitely. Perforated they have mentioned. CEAP classification. You have to know the details of that. We are not going to discuss. They can read, I think, sir. CEAP 6, all 0, 1, 2, 3, 4, 5, 6. 7 of them, not even the 0. 0, 1, 2, 3, 4, 5, 6. So it is healed ulcer becomes C5. That's of exact she has put E etiological, A anatomical, P pathological, reflux or obstruction. So that is a detailed classification you have to remember. Exam is a short note for you. So in long case also they will ask detail about the R. Now R they have added for recurrence. So you can just go through the books and read those things. If it's important, short note. Viva they will ask, and MCQ they will ask in the NEET exam. Oxy also they may put. So detailed classification is very important to know. So go through the books for that. So without signs of DVT, she has mentioned. Complications, she said, what are the complications? Perforators, great saphenous vein, she has to mention. So that is, except she has to mention the which vein. Other things are okay, I think. Okay. So we'll go to the, now this slide, it is very clear, sir. Vein is very clearly seen. Although very torch was nice, vein is very clearly seen actually. So if there are short saphenous vein, you have to do a tourniquet test for short saphenous vein. That is a point very important. Okay. So we'll go to the next slide. Somebody, Devika, you are telling investigations or Devika?
Jivika.
Investigations. The gold standard investigation is duplex, B mode, Doppler ultrasonography.
Okay, what B stands for?
The B mode.
I'm not sure.
Yeah, B is brightness mode.
Okay.
And this is M mode. For echocardiography, heart, there is a motion mode. Here is the brightness mode. So you should know the full form.
Okay, sir. Okay. It identifies the reflex at saphenofemoral junction and its incompetent perforators and thrombosis. On handheld Doppler examination, it can tell us the direction of flow and the valvular competence. In ascending venography, deep venous system. And for ABPI or ankle brachial pressure index, it rules out arterial insufficiency before the stocking. Ultrasound abdomen and blood parameters like CBC, PTINR, and APTT.
Okay. Sir, okay. Anything to comment on this, Manoharan, sir?
Sir, ABPA, is it necessary for this case?
Yeah, because peripheral pulse is felt, no?
No, when you examine peripheral pulses, it is there means I don't think there is no.
If peripheral pulse is felt, because don't unnecessarily bring the problem within you.
Then they will leave this and start talking about AVPA.
Ultrasound abdomen, blood parameters okay, thrombos, all those things, handheld Doppler, other things are venography. Usually we don't do, no sir. We want to do.
We don't do.
Mainly Doppler, ultrasound abdomen.
How do you locate the perforators before surgery?
By injecting a radial.
No. We examine the case. Next day, the patient is posted for the surgery. So they have to locate the perforators.
Okay.
So who will locate and mark it? You have written there. You send it to the radiology department in the morning.
Yes.
Yeah.
So the patient will stand, the person will be sitting. You can see the picture in the textbooks. Okay, they run the probe along the course of the vein.
Yeah, that's standing. You have to
mark it.
Okay.
So with those markings, only patient will come to the theatre.
Yeah,
Okay.
Because they're going to operate when the patient is lying down.
Okay.
So how do you locate the perforator? So you make incisions over the markings. What do you call? Stab incisions.
Okay, sir.
Through the stab, you will put an artery force and hook the veins. It's called stab avulsion.
Okay.
So that is how you do. So that perforator location is by the radiology department.
Okay, sir. Okay.
That is the only thing.
Generally, vascular cases avoid invasive procedures.
Yeah.
Yes.
Unless it is indicated. Absolutely indicated.
Yes, sir. So that's the point. Yes, sir.
APTT INR is not routine unless patient has bleeding diathesis.
Yeah.
Okay, sir.
So routinely you cannot ask. Yeah.
This that point is very important, sir. Sir has pointed out. Doppler should be done in standing position, and vein should be marked. It's called a venous mapping. So the radiologist will do the venous mapping and send the patient for you to you in this OT. Okay. So without mapping, you will not do surgery. That is
main standard for doing this Doppler is what all this superficial vein, this incompetence and various tests and all we can do. The only thing which you cannot say is what? Deep vein.
Yeah, that's important.
Main thing is that one. The other things all clinically you can make out. But deep vein, we don't know whether it is patterned or the only proof is by doing imaging.
Another thing, deep vein thrombosis.
Yes, sir.
Should be ruled out by Doppler.
Yes.
Because why DVT?
Why you are so particular about deep vein thrombosis?
The management will vary if it's a DVT.
Like what?
No longer, we do not do foam sclerotherapy if there is DVT. It's
we don't do any therapy.
Anything.
Don't do anything.
Don't do anything.
No therapy. Not to break heart, that's all.
No SRB ligation.
Even patient has a fracture or whatever it is, you don't do any intervention at all, but deep vein is thrombosed.
Why you don't want to do it? What will happen if you do surgery?
In this case, you have a dilated vein, you remove this superficial vein, and there is deep vein thrombosis. What will happen? Sorry, sir.
Doppler show DVT. You have done the surgery. What will happen to the patient? Understood now why you don't want to do surgery? Devika, Jivika.
Pulmonary embolism.
Not pulmonary embolism.
There are two systems, simple, two superficial venous system and the
Deep
vein system. The deep vein is thrombus means what is the only system functioning?
Superficial.
Superficial.
If you block that one also, what will happen?
Venous system. So you remove the superficial vein, there is no venous return at all.
Blood will not. What will happen to that limb?
Limb goes in for
Venous gangrene.
Gangrene.
So we will create venous gangrene. So don't ever do any intervention at that point of time. That's why that's very important. So there are so many points which sir has told in Doppler. Remember, one is in standing, make a mapping. Second thing is always rule of DVT. If there is DVT, no intervention. That point is very clearly sir has told. Because if you do any intervention, there is no blood drainage at all. No venous drainage. You are blocking all venous drainage. Limb will go for venous gangrene. It will be very, very dangerous. They'll have sepsis. May lose the patient as such, not the limb also, not just limb. May lose the patient also. So don't ever do any intervention at that point of time when there is DVT, when you do an ultrasound Doppler study. Okay, that is a point very clearly informed by the professor, Sir Manoharan Sir. Is it clear? Any confusion?
Yes, sir.
Okay.
No, sir.
Sir, it's important. Thank you, sir. The point is very important. I should know. So we'll go to the next slide, sir.
Yes, sir.
Yes, sir. Yes, sir.
Next slide. Treatment. Just tell Jevika or Divika, anybody. Just go through it.
Initially, we go ahead with conservative methods, thus compression stockings or graduated external pressure. And then surgical methods include the Brody-Trendelenburg operation, subfacial ligation of perforators, stripping of the vein up to the knee, endothermal radiofrequency ablation, endovenous laser ablation, sclerotherapy, and foam sclerosing.
Okay. Currently,
You should actually separate now. This is the open procedure is which one? Open surgery.
Trendelenburg.
Trendelenburg operation. Then that is stripping is also part of it. That is all open procedure. What are the endovenous procedures?
Endothermal radiofrequency ablation, endovenous laser ablation.
You have not mentioned that. Radiofrequency ablation, endovenous laser ablation. Then we have endothermal. You have written that venous and laser.
she has written, sir.
Yes, subfacial, endoscopic, perforator ligation.
Yeah.
Second
What is the
point.
temperature in the radio frequency?
I'm sorry, sir.
What is the temperature in the radio frequency?
80 to 120
Yeah,
degrees.
85 degree or 100 around. Okay. Laser. Laser, what is the temperature? Which is got higher temperature, laser or radio frequency?
Laser.
Laser 700 to 1000 degree, where this is 85 to 100, rather less.
How these two will work? Both laser and radio
How
frequency.
it works?
So the irradiation and then it will heal by
Radiation.
sorry, sir. Increasing the temperature and
What
the-
happens? What happens?
The
Those-
tip of the catheter is inside the lumen of the vein. So the heat will what will happen to
it
the
will
vein?
coagulate.
It will coalesce and then stick. So the lumen is obliterated. So that's how we remove it.
The purpose is to obliterate the lumen. To obliterate the lumen. But you cannot use the word radiation. Radiation here.
I'm sorry, sir.
Don't use the word radiation.
Tell me some sclerotherapy. You said what drugs you use?
This ethanol oleate, sodium dodecyl.
Sodium tetrahydroxyl sulfate, STD. Okay, foam sclerotherapy currently we do. We do foam sclerotherapy currently.
Where you use foam? For which case?
It's for multiple occlusions, so that in one
Small veins. Just you written the previous slide. Reticular veins.
larger size.
No, larger size. You have to go for endovenous procedures.
Not a smaller reticular veins or below knee level.
Patient comes back after 6 months telling here and there are small veins, hair-like.
There
On
you
those
go
veins
for
you use the foam
foam
sclerotherapy.
sclerotherapy. Yeah, have you seen foam sclerotherapy?
How you create the foam?
How will create foam?
There is air also added to it in the ratio of 1:4, and
5 plus 1. 1
5 plus
ml and 5 ml or 0.5 ml to 5.5 ml. 5 to 6
Use
ml.
three-way cannula with multiple syringes.
Yeah,
So inject the air and the sclerosum, mix it up. What do you call that method?
Steps method.
Tessari's method. Yeah,
Tessari's method. Yeah, okay.
Okay, man.
So that is about all this management. There are so many names are there. SEP is there. The endoscopic. This one you have to read the book because Trendelenburg operation at Walden is the gold standard now. Slowly it is switching over to the endovenous laser. All endotherapies are common now. Sclerotherapy and endotherapy. But still in the exam they will ask what is Trendelenburg operation. Otherwise called as
What is the conservative management of managing a varicose ulcer, man?
what is it called as?
Brigards.
Bisgard.
Bisgard.
Bisgard method. What is the spelling?
Bisgard.
Spelling.
BISSGARD.
Double S. Jivika, what is the spelling? BISGAARD. BISGAARD.
Bisgard. Okay,
What are
sir.
the components? What are the components of Bisgard regimen?
They give so topical antibiotics are not used. Instead, there's pressure given, negative pressure is given.
Mainly elevation.
Elevation.
Elevate the limb, empty the vein, and keep the vein empty by applying. What do you apply?
Pressures.
Stockings or crepe.
Oh.
Okay. And
Compression bandage.
active and
Compression
passive
bandage.
exercise. That is the
When
main
you apply
component.
something on the ulcer, you keep something. What is that called?
Dressing.
There is an ulcer. No, that is why we do the conservative method. So now over the ulcer, what you are supposed to keep? So Sir has mentioned 4LB. What is that?
Uh,
I don't know. Sir will tell. Yes, sir. Please tell, sir. You have to apply 4 layers of bandage.
Unna boards. Unna dressings.
Unna.
That is Unna dressings. 4 layer of dressing. Elastic dressing.
Ulcer area and the congestion
4 layers
edema.
you remember. Unna dressings.
So that how much pressure
Maybe elastic and inelastic dressings. Okay. So that's important. Often you use all also. Okay. So important thing what sir is telling is you have to reduce the venous pressure around the ankle, so that increases the perfusion and promote the healing. So what is the normal venous pressure around the ankle?
80 to
It is
80 to 120.
no, normally is around 20 to 30. It is increased. Venous pressure is very much increased. Venous hypertension.
Venous hypertension, ambulatory venous hypertension.
80 or more. So that's why perfusion pressure is decreased. That is why there is hypoxia. That's why all this problem occurs. Understood? So decrease the venous pressure by limb elevation, active exercise, passive exercise, all those things to promote the ulcer healing. So that increases the perfusion by reducing the chronic or controlling the chronic venous hypertension. So basic cause for all these problems around the ankle is venous pressure. So chronic venous hypertension is the main cause. That point you have to remember. That area is called Gaiter's zone. You remember, no? Gaiter's zone. So
Yes.
head breath around the ankle. All those problems, even the veins are high up. Problems occur around the ankle. That is called Gaiter's zone, where venous pressure is very high in this diseased limb. So that you have to control. That's the reason why sir has asked why you want to elevate Bisgard method. So reduce the venous pressure, improve the perfusion, promote the healing. That is the idea. So venous pressure reduction is the most important thing you have to concentrate. Okay?
Which muscle is important for this venous return pumping action?
Soleus.
What does that muscle has? Correct? Soleus.
Soleus.
Yes, what does it have?
Sinuses. It has venous sinuses in it.
Venous sinusoids filled with blood.
Inside.
So when it contracts, the blood is ejected towards the heart. Yeah, that is what it is.
So venous ulcer are also important. Complications of varicose vein, complication of venous ulcer, marginal ulcer, periostitis, thickening of the bone you have to look for. Important. Run your finger over the bone. Other things also important. So
What are the investigations for a non-healing venous ulcer? Chronic venous ulcer.
what important investigation you will do? If there is a venous ulcer.
Biopsy.
Biopsy forward when you suspect malignancy.
Yes, sir.
Routinely you don't take biopsy, no? With 1 centimeter ulcer, you keep on taking biopsy, it will become 2 centimeters.
Blood glucose. Initially.
No, what complication can occur in venous ulcer?
Locally, what investigations? I am not asking systemic.
Other than periostitis, talipes equinovarus, fibrous ankylosis of the joint. What important complication, rather dangerous complication can occur in a chronic venous ulcer? Scar forms, breaks. You said healed scar. It forms again, ulcer forms, breaks, breaks.
Margulins.
Marjolin ulcer.
Yes. What is margulins?
Squamous cell carcinoma caused due to long-standing
It comes only in 2 conditions. One is
burn patients.
post-burn scar and the chronic non-healing venous ulcer.
Yes.
Okay. It is a
Underlying the ulcer, what is the base of the ulcer?
What is the base of the ulcer?
What is the base of the ulcer?
In the venous ulcer, it'll be there'll be pale granulation tissue or even absence of
Base.
Base.
You are telling about floor.
Sorry. Yes, sir.
What is below the floor? Bone.
Bone.
So if it is infected, what do you call it?
Osteomyelitis.
So that you cannot clinically make out.
Periostite, it's a periostite.
And osteomyelitis, you take X-ray and see
Yeah.
the underlying bone is infected or not. Okay.
Currently, we'll do MRI. Ideally, usual basic investigation is X-ray.
X-ray
Bone
or
thickening will be there. So base is formed by the bone actually. Okay. So there are so many things you have to read for treatment management of particular very common entity with the high morbidity. Okay. So next slide, sir. Here give a small conclusion, sir. By then I'll go through my slide.
yes, sir.
Deepak, just to open my slide, sir, about how their presentation also give a highlight, sir.
So both did very well, sir. Only thing they were little in the end they became hesitant. Otherwise, slides were very good. Slides were all the clinical tests you are individually elaborated. I should appreciate both of you for.
There are some hurdles, so they have got confused about the modified
Yes,
purchase,
yes, madam.
which vein they have not mentioned.
Both of you are fond of arterial disease, I think.
It's a difficult case actually. Varicose vein is very complex disease actually.
But presentation is
Well,
good. Both of you did very well. Congrats.
definitely very well because it's a difficult case. That to online to present not that easy, but they have used their presence of mind and answered.
Yes, sir. Yes.
Sir, your students are good, sir.
Thank you, sir. Thank you very much for the compliment, sir.
Not that easy. At their level, good.
Thank
They
you.
presented well because it's a difficult disease to manage, understand also very difficult. Management also very difficult. I'll just go through briefly about the examination in 5-10 minutes. We'll finish within 5-10 minutes, sir. Muthukumaran sir, your
Yes, sir. Yes, sir. Please, sir. Please, sir.
and just go through. So next slide. Next slide. So just see this slide how it is defined. I'm not going to read this one. Dilated, tortuous, elongated. It's very, very important. It is inelastic, pouch, or friable. So it's very common. Remember, 20% population. So you have to name actually great saphenous or short saphenous or communicating or perforator. You have missed that. And perforators, all these names we have discussed there. Sir has asked, of course. We can just MCQ is very important. Communicating guns are a little different. It is from the one vein to other vein, superficial tune to other vein. Now, important communicating vein, which you have to remember, is a geocommunicular communicating vein and anterior accessory GSV, that is in the thigh, upper thigh.
This point they will ask in the examinations.
Sir,
What sir has written?
yeah, sir is very fond of this question. Giacomini, what are these lines? One is from the posteriorly long saphenous to short saphenous vein, another is in the upper thigh going into the long saphenous vein. They are communicating with one vein to other, superficial vein. Perforators are perforating the deep vein, superficial to deep. So meaning differences are there. That's why they put this slide. Next slide. So just the same back, go back. So the orderly fashion, chronological order. Night cramps is important, which you have missed. Even negativity there you have to mention. And heaviness also, aching sensation I have put. Actually, probably word is for sir has told rightly. Heaviness in the cough is very common feature. Features of complication. So orderly chief complaint you have to write. Next slide. So this is the history I have put in a slide actually to easy to understand. Dilated vein, pain, other night cramp, severity, heaviness. I have put everything. Swelling, whatever sir has asked, everything is there, sir.
Yes, sir.
Manoharan sir. Ulcer, bleeding leg, bleeding. Keshav has asked bleeding history. Fever, trauma, deformity, mass abdomen. You have mentioned that. Positive surgery, positive DVT. This was somewhere Keshav has asked DVT history. You have to ask. Surgery procedures, trauma, laparotomy, malignancy. We have discussed smoking, pregnancy, females, alcohol, obesity, family history. 3-generation family tree you have to mention, of course. Some syndromes you have to read and remember. It will be asked in the exam. Sir has already pointed out. Drug therapy, cardiac drug, diabetes, hypertension, all those things, spinal disease. This is the history slide. If you remember this slide, you'll be able to recapitulate and present actually. Next slide. Next. General exam, I'm not going to detail that. Next. Examination, disease limb first. And both limbs standing. That point is important. As you have mentioned the slide, I can't recollect. First standing, then lying down position. That's why I put the underline. And again, inspection, dilated veins, saphenous from see that below to ankle to thigh. You have to examine fully. This is what sir has I have told actually. Manoharan sir, most of the things he has mentioned actually, has detailed actually very nicely. Maurice's comfort in lying down position. Ulcer, sir has discussed at the end. And lipodermal champion, motor signs, swelling, gaiters area we have discussed. Bone thickening, again at the end, sir said periostitis. Chos test and DVT test modified perthes, and hormones we don't do it, but I just mentioned that. Then these tests are you have already told. This. The test for SSV is important. 3 tourniqueted or multiple tourniqueted. Prods test all them for academic intent. Fagan test blowout. Yeah, we have discussed it in test. Sir has told that very clearly. Remember Fagan test standing and then lying down. No tourniquet is placed, user for Fagan test. Don't get confused, okay? And Mercy's cuff people done in lying down position, okay? You have to feel a thrill. So this is how exactly you'll do the impression, palpation, these special threads. There are so many other special threads. This much at least you have to remember when you present a varicose vein. Next slide. Next. So measurement of limb girth, marking of the perforator. Sir has already told during Doppler in standing that sir has detailed auscultation, breathe, some peripheral pulse, immersion lymph node, joint. We have discussed active and passive movement. Ankle is dorsiflexion, plantar flexion, and subtalar is inversion, eversion. We are told the difference. Keshav has discussed very clearly. Opposite limb, gait to check that telepathic virus, abdomen exam, respiratory chain spine. Give complete diagnosis. Venous as right leg, middle as right ankle, incomplete GSV, grid saphenous vein. You have mentioned which vein, below knee perforator, no evidence of DVT. Most of the things you have mentioned, a complete diagnosis you have to give when you give a clinical diagnosis. Okay. Next slide. Next. So venous Doppler with the B mode Doppler scan. Sometimes they look what you look for: saphenous eye, Egyptian eye. All those things are if you're able to recollect and tell, that is good. Blood test, ultrasound, discharge study ulcer, wedge biopsy. Sir has already discussed. Why biopsy? He said marginal ulcer. Special tests, varicose not commonly used. Of course, phlebography. See that? Sorry, special investigation. Phlebography. All these things are not used nowadays. So unless they are asked, don't mention. It's very difficult to remember. They're very difficult to understand because we are not doing it. Okay, main is a venous Doppler. B means bright mode. That point, remember. B is full form is bright mode. Okay. Next. So treatment in Tennerenberg operation, good old procedure. Now it is switching over to the newer method, sufficient like stripping, avulsion, stab avulsion. Sir has told how to. Sir has mentioned that laser endoscopic therapy and clearotherapy foam. Also, we have discussed what drugs. Bisagard spelling. Remember, sir has asked that. BIS. What are things sir has discussed? GAARD spelling. What are the components? Chronic venous hypertension is the cause. Treating varicose vein later, skin grafting, all those things are the required thing. You have to just go through it and recollect. In the exam, it will be discussed. Next slide. So this is the ulcer. See that this reticular veins here. Ulcer is there. How exactly veins are seen? Next slide. So veins, you have to mark it out. See the next slide. Ulcer, both sides. So remember, it's a long case, short notes, and main question MCQs. Examination standing, different tests. Look for DVT, CEAP classification. We have discussed that. It's a short note. Venous Doppler approach, surgical anatomy veins are important. This also partly discussed. Sir has discussed. Of course, you can go through it in detail. Extensively surgical, and these are the things which you have to remember when you consider varicose vein and you present. Next slide. Next is to inspect both sides from front and behind. That's what sir has pointed out. Both sides you have to examine. Short saphenous laterally, behind, front. See that? Next slide. See that? Anterior, front, behind. Understood? Next slide. See, tourniquet, ideally better to use tourniquet. See that rubber tourniquet there. Otherwise, bandage you can use. Sir has told 4-inch bandage. Okay, elevation. This is called milking of the vein. Okay, not tapping. Next slide. So this is the multiple tourniquet test. Next slide. See, this is the marking out blow. This is the Fagan's test. See that in standing you mark it out, then elevating again depression you can feel, crescentic depression. Typical Fagan test, both in standing and lying and elevating the limb. Next slide. This is the lipo. This is the champion bottle sign. Lipodermatous. This is the gaiter's area. See that? This is the gaiter area. Typical, exactly where all those problems occur. Okay, gaiter area. This is the lipodermatosclerosis with the champion bottle sign. Okay, inverted champion bottle. Next slide. So cuff impulse, short sign, Cruviller sign. In standing, it is called Cruviller sign. And this is in lying down position. Morris is in the lying down position. Remember, you can see here saphena varix. In the put the finger there. So tourniquet. See that tourniquet you have to apply. Bone thickening you have to look for periostitis. Again, sir has discussed ulcer examination in all. You can just go through that. And joint movement also important. Ankle joint and subtalar joint. We have discussed that one in detail. Next slide. So this is the stripper, Meyer stripper. That in the exam they will ask. So just to imagine, go through those things: Meyer stripper, extraluminal, intraluminal, different. That in my book it is there. You can go through all books, whatever you want, and remember these things. Stripper is very. This is the Meyer, M-I-E-R, Meyer stripper. They will ask what stripper is used in the exam when you discuss about the management. Okay, this is the stripper divine actually. Look at that. Next slide. So this is about briefly varicose vein, but very common long case. Most of the things MCQs also they will ask. You have presented, students. You have presented very well. Of course, difficult case it is. So many questions we have asked because understanding very complex system. It is a very complex, very system. So you can go through my books. Clinical book is there, lecture video is there in the clinical varicose vein, how to examine. My manual is there, uploaded surgery is there. Mainly my website. All of you can subscribe. It is free actually, and these live sessions are there. Sir is there, my guide, Manoharan Sir, Guru rather, Muthukumaran Sir, my good friend. Sir is there, and always go through website or some daily MCQs there. You can try to answer those MCQs. It will be useful for you. Daily I'm putting one on MCQ in my website. You can answer that. And I request everybody to subscribe my website, make use of it to learn surgery in easier and better way. Of course, my book and my clinical book is there. Everything is covered, whatever I said. You can always put comment in my clinical book or about my book. Any mistakes is there, you can put. So it will be easier for me to do correction. So again, thank you very much. They presented very well. It's a good for them.
Both Deepika and Deepika did very well. Only thing you should talk a little more bold.
You won't be able to answer everything. Understood? It's easier to ask question from our side.
Yes.
So it is difficult to take the question and answer. You have done very well. And sir, you have guided them.
No, sir. Clinical testing slides were very good, ma. Very well made. Each and every test you have highlighted. So that is the way.
The chart slide is good. Sephnofemoral. That
last one that that is also very nice.
That is very nice actually. And presented well, sir. They have presented well. Of course, there will be shortcomings. It's not easy to learn. Sir, Manoharan sir, thank you very much
thank you,
for joining. Keshav, I thank you because in between he had an emergency case, just left a few minutes back. It's okay. So request everybody to go through the live sessions and join next live session whenever possible. And student Devika and Jivika, ask all your friends and subscribe my YouTube channel and go through the sessions or lectures are there. Make use of it. So thank you very much, sir, and for spending time. Muthukumaran sir, thank you very much.
Sir. Thank you very much, sir.
Thank you very much.
Thank you.
Good night.
Thank you.
Thank you,
Manoharan sir.
Very well. Thank you. Good night, sir. Good night.
Right,
Sir.
good night, sir.
Good night, sir.
Thank you, sir.
Thank you. Thank you, Devika. Thank you, Devika. Presented very well. Okay.
Right.
Thank you, sir. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, Divika.
Thank you, sir.
Thank you, Divika.